declarations of interest. Anyone want to declare any interest? Still interested? Yeah.
Waning.
Okay. Okay, very good. Approval of the minutes of the 8th of May. Yes, Tracy.
Very minor things, but I just wanted to, can we add at the end of the minutes where we talk about having moved the meeting to make it more accessible, can we add particularly for people from 4 given the agenda item?
Yes, thank you. Okay, I'll record those as approved. I believe we have no public questions.
No public questions.
No public questions. So, Terry, can you take us through the action log, please?
Yeah, so the action log. One action outstanding, which is with me, which is the compilation of a board decision log. That's now done up until the end. I think we're in the process of completing.
Any other points on the action log? Yep.
Can I just reference Health Watch? We had the mental health report that we were going to bring back to this meeting. I think Debbie was going to bring a report, so I just think it's important we don't lose that and maybe have it for the next meeting. I don't think Debbie's here today, so
No.
yeah.
So we still have some.
Thank you, John. This month's vignettes feature stories from 2 sets of groups. This includes people from our Diabetes Expert Reference Group, which is a group that's been established for over a year now, and also from engagement with our deaf community. The films show the stories of how we've listened to people's experiences and then also sets out the changes that have been made as a result of lived experience. We're really proud of the work that's been done and that's been supported by our board members, so particular thank you for allowing us to bring those back. The films are quite extensive. They cover the airing of some new Diabetes UK films that have been done in partnership, made in Cornwall and are now available nationally, which we're really proud of. And later on today, we've got invited members of our lived experience groups also attending. But you will see that we're basically bringing together clinicians and people of lived experience side by side to co-produce and make changes that will impact and make things better for the long term. Thank you.
Okay, Tom.
I really welcome the vignettes. I always think they bring to life the reports coming into board because they bring real people's experiences. And I think they've been a real great asset to our board. One push I would have is that we don't just look at conditions, that we really start to look at intersectionality of where people are born, the family that they're born into, and the experiences that they've had, and how that then impacts on their health and well-being. So great work. Let's keep going in the right direction. Thank you.
Any particular one anyone wants to pick out? No? Another great set, by the way. I think we learned so much as we go through this. Yeah. Okay, let's move on if there's no other points on that. So in terms of the chair's update, so I'm going to verbally update it, although I've shared with Terry more of a written one. The reason why it's another verbal update is that I wrote it on Monday night, and by Tuesday morning it was out of date. So I just thought, I have said to you on a number of times, by the time I write it 10 minutes later, ask me again, because it'll change again. So I thought it better to try and give a more contemporaneous update as I go through this, both in part 1 and in part 2. So apologies if it's going to feel verbal update again. Can you believe it's been just over 3 years since we started? So this isn't just going to be an update on the last month. I'm going to do a bit of an update on looking back over the last 3 years, if that's okay. And why are we doing that? Because the Secretary of State has, with the national NHSE team, decided to go from 42 integrated care boards to 26. Is 26 now? Yeah, 26 integrated care boards. Some aren't changing and clustering, some are, and where we're looking to cluster across Cornwall, Scilly and Devon as we go through the summer. Also, there's been the CSR, the Comprehensive Spending Review, that's given a relatively better settlement for the NHS compared to others, but still stretching for us. And most notably, two main reports. One is the 10-year plan, which must become our guiding light. Interestingly, there's lots on that 10-year plan that we recognise from our own 5-year plan, so pleased to see a lot of that. But that should become our guiding light. And for those who haven't had the time to read the Penny Dash report, I seriously advise you to take a look at that as well. For me, they go hand in hand. If we do look at the key themes that are in the 10-year plan, that are in our own strategies as well, moving from a focus of sickness towards prevention. There's a number of examples I can cite in a second where I think we've achieved that, and achieving that increasingly over the last 3 years. Moving treatment from hospital to communities, a theme that we mustn't draw back from. And I'm sure that will come up in this morning's part 1 and in this afternoon's part 2 meeting as well. Shifting analogue to digital, Kelvin, a theme I know you've known well, but increasingly so not just for back office, but increasingly for the way in which we use it in frontline services as well. So I think if we look at what we've achieved, there are a number of achievements that I just sort of want to pick out there. We'll be one of a few integrated care boards around the country to have broken even for three years since we started. The benefit of that, of course, which you've heard me say before, was getting £140 million worth of debt write-off. That's not a small achievement, everyone. So congratulations to all teams to have got to that point. Looking back over the last 3 years, it's just some of the things I wanted to pick out. Same-day emergency care centres, community assessment and treatment units, diagnostic centres, investment in and movement towards closer to home by investing in, I think it's nearly now 60 community health and wellbeing workers. The way in which I think we as a group work as a system has matured since we started. I could go on, I won't, but I think there are really some very sizable and seismic shifts that we've taken. And Stuart, seeing you in the room, I have to say the contribution from the GB Collaborative and General Practice has been a material input into the way in which we have worked as an integrated system and the way in which we go about moving from hospital into community. So thank you particularly. I didn't want to pick anyone out, but I just want to say thank you to you and your colleagues. If you could pass on my thanks, I'd be very grateful. But we shouldn't miss some of the other major investments. For example, RCHT has managed to achieve with government the Women's and Health and Children's Centre, a major £300 million plus investment from memory. 350. Thank you for updating me on that. £350 million. We shouldn't forget that. There's the St Austell elective hub that we put in place, another material change. A lot of the work that Margaret, you and your team have done in CFT, huge changes in what we're doing. And we'll pick up a lot of this in the annual general meeting this afternoon, but I just thought for some of the public who won't be at our annual general meeting, I just want to touch on some of those. I was asked to pick up, Susan, if I missed any of this, maybe you could help me here, on the SEND Joint Commissioning Strategy for Special Educational Needs and Disabilities. Is there anything that you need for us while I'm on SEND to minute or share with the public?
I think we've agreed both the strategy working with our colleagues in Council and Education, and we've also agreed the commissioning strategy. So there was two papers that we've brought to board. So I don't think there's anything further. Thank you.
No? Okay. And therefore, just finishing off, we will talk as the day goes on about clustering and what that means, but I just want to reach out particularly to the Integrated Care Board's staff, who of course went through a 30% cost reduction exercise not that long ago, certainly within the last 18 months. The way in which they're dealing with the issues that are around change, looking towards the 50% overall, if we take out safeguarding, CHC and medicines management, that we're going to have to achieve. Some of the delays, Kate, I just want to say congratulations to you and the executive team on an excellent briefing to staff that I sat in on, and the way in which I thought our staff dealt with what are difficult messages in a very mature way. So I just wanted to reach out to all of them, and I hope you didn't mind me sort of labouring this point, and just say thank you to you, your team, and all our teams who are going through difficult stages, because this is going to take us through probably into May and June of next year, I'm afraid. And we can touch on why as the day goes on. So, finishing off, So this is our public board meeting. This afternoon we have our annual general meeting where we're going to be celebrating some of the things that we've done over the last 3 years. But happy to pick up anything that you want now. If not, we can move on. Anything you want to ask about my chair's report? No? Great, thank you very much. So, Kate, over to you on the Chief Exec's report.
Thank you very much. So you have in front of you quite a comprehensive Chief Exec's report for this month. So some of it replicates what John has previously spoken about. So there's a section on the cluster update, both our cluster and the other clusters that are formed across the southwest. It's clear that we aren't going to be releasing the 50% savings that were anticipated during 25-26, and other ICBs have baked that position into their plans for 25-26, so it's good that we haven't. We are just working with Devon ICB and also regional colleagues to work out how much we can afford to change in year. So what level of changes we'll take forward as part of clustering. And we will be advising the board our affordability as we move on. Our priority is to continue providing high quality patient care and to reduce waits. And that's fundamental that we continue to see this as a foundation for the delivery of the 10-year plan. But also we've already made a commitment to people through our annual operating plan for the changes that we'll put in place this year. And later on in my update is some news around integrated neighbourhood teams. 10-year plan's been published, and for us, actually, it isn't an astounding document. It's great, and it provides a high level of challenge for all of us, but it does build upon the work that we've been doing and enables us to talk more about that shift from institution to homes, and our tagline of caring where it matters, being caring in the places that the people would like to be looked after in. So it is heartening to see. We've had our ICB annual assessment letter and we've attached the letter as Appendix B, but effectively it says that many areas of development have been highlighted and we've been assured that areas highlighted for further attention are well known to us and are already covered off by our delivery plan. So that's nice to see that as we be the last time Paul and Nazareth gets a letter in its own right. I just wanted to highlight the work of Work Well, and there's a few paragraphs in the report, but also I visited St Austell's integrated neighbourhood team last week, and Seb, who is their pain social prescriber for pain. The work he's doing around getting people back to work, we need to link into Work Well. So I've already engaged with Patrick and we'll be talking to Jessie Lee about it because they are already doing that work in St Austell, and if we could scale that up across the county, that is the fundamental principles of Work Well. So I think we should be building on the skills and talents we've got around the county. Following the spending review, we've been advised that the government plans to extend Work Well to 28-29. So working across our statutory organisations with the innovation and the agility of our voluntary sector colleagues, I think we're in a great place to be able to do more over those years. The dental contract consultation is open, and I think you'll remember Finn Basson, who is the dentist at Lostwithiel, who opened the pilot around having vulnerable people on his dentistry list. He's now been asked to go and brief Stephen Kinnock, Minister of State, and also to work with the British Dental Association around how that pilot or the principles around the pilot could be spread elsewhere. And there's also an academic evaluation from 2 universities, I think it's Liverpool and Birmingham, going on to see if how the commonality of those principles could be shared across the country. Safety and quality across the NHS, so a review led by Penny Dash is very refreshing, so I absolutely concur with what you said, John. There was a chief exec meeting while Steve was on holiday. Debbie and I went with Kim O'Keefe, where Penny presented her work, and she's really clear that safety, effectiveness and patient experience are all quality. None of them can exist without each other, and we've become way too safe and not quite as effective. And she took us into our workforce figures, where effectively we've wrapped workforce around people, which has cost more money but not necessarily given us the outcomes around effectiveness and patient experience. So I think that is something we are going to definitely have to get into over the next year or so, how we're using the resource of manpower. And Elizabeth O'Mahony also put up startling finance slides around our finances over the last 3 years, which we are going to circulate so that we can discuss in a bit more detail in part 2.
Who's circulating them?
Simon, you circulated them?
You are circulating to the whole board?
Yeah.
Yeah, thank you.
But one of the things that came out for me is that as a nation, we pay more on outpatients than we do on primary care. And if we look at where the balance of value add to people's lives sits, we need to start addressing some of those that disparity. We've had our public health assurance visit from Justin Varney-Bennett, who has written to both ourselves and the council. So Union will be very proud as our Director of Public Health that Justin finds that we work really well together, great team working, lots to build on. And as we go into a Cornwall-Devon cluster, we've got loads of great work to take into that. As part of our new operating model, the role of public health is writ large, and how we work across our public health, our DPHs will be really important moving forward. We've had the Future of Women's Health, Access, Equity and Action. Dame Leslie Regan came to host that as part of her work as the Women's Ambassador. And Tan's point around intersectionality is really important. So outcomes for women's health are poor. Once you start adding other deprivation or protected characteristics to women, you start seeing plungingly poor outcomes for women. So when we're now getting into being much more specific around inequalities in health, inequalities in outcome, we need to be very clear about which parts of our population we're talking about. It goes back to Tan's point around intersectionality, not just disease groups, but who we're talking about. And I think as we get into our new strategic commissioning world, it will also be who are we treating? So where are the people who should be being treated as opposed to the numbers going through contracts, which I think will take us all back to the place that many of us started out. Industrial action, less of an issue for us as a board, much more of an issue for our provider boards, but our junior doctors or resident doctors have taken a period of industrial action that could go on for up to 6 months. Great management of it by our providers across the patch. We were congratulated this morning as ICB chief execs for our tireless efforts to make our county safe. I think we need to take a step back and say it's not us. It's actually the tireless efforts of our providers that are making our county safe. And we need to hope that the BMA manages to get a resolution with Secretary of State for Health as quickly as possible, because maintaining safety for our patients should be our #1 priority. In terms of neighbourhood health development, we've been asked to apply along with everybody else in the UK to a call for bids around integrated neighbourhood health. Just as this was coming out, the Department of Health came to an INT showcase workshop along with the National Association of Primary Care. It's fair to say that Paul Moback, who's one of the special advisors in DH, left Cornwall absolutely amazed at the work that's happening across our county. So on his advice, we're putting in a pan-Cornwall bid based on our 3 places, but looking at the differences between our 3 places. So, for example, the interface in the north and east is much more with Plymouth, UHP, who are putting their doctors actively into Liskeard, Launceston, Looe, Bude and Stratton. And Mark Hackett and I spoke last week around his plans to expand that further. So that will be one model that we'll put forward as our integrated neighbourhood team development. And then, of course, across central and west, we've got a community-based infrastructure with much more team-based work around the integrated neighbourhood team. So I think we'll be able to do a compare and contrast, which will be great for the application. Ali and I co-sponsored a meeting yesterday between the local authority, the NHS and all of our non-statutory colleagues. So we will be putting a bid in that will be signed by everybody, the council, the NHS, our trusts, patient groups, general practice, hopefully the LMC actually. I've just thought that while I was thinking, so that we've got everybody's signature as a really clear compact between the ICB, the council and people who support others across Cornwall and the Isles of Scilly. So I think that's very exciting. And I think that is that for me. Thank you very much.
Any questions? Yes, Emma.
Thank you. I just wanted to raise the fact that in the southwest we've got agreement.
It's not working.
Yeah. Better? Yeah, there we go. In the Southwest, we've got agreement for VCSE representatives from our alliances to be part of that neighbourhood health regional sifting programme, which I think is really exciting and again shows the Southwest leading in having VCSE right at the heart of our regional working. We're also trying to influence Nick Gitcham and others at the national team to have VCSE representatives on the national panel for those neighbourhood health. Clearly it won't be me because we might have a bit of a conflict of interest with Cornwall putting a bid in. So that's really exciting. But the other thing I just wanted to raise, and it might not be for now, and I know we don't have the answers, but given that we've seen since our last board meeting, the announcements around the abolition of Health Watch as a function, some thoughts around how we, from a council and an ICB perspective, are thinking about that function remaining over into the future, and how we think about that continuing to be an independent voice for patients and people across Cornwall and the Isles of Scilly.
I think that's something we need to pick up as part of our building our structure going forwards. But the point about the bid, I think that is apposite, because the way we work in Cornwall isn't the way everybody else is working. So depending on which partner talks to you about the bid process, because Claire Fuller will be GP at scale, it needs to be a general practice-led bid. Tom Reardon will be it's a local authority-led bid around neighbourhood, and there's another person doing the talking, I can't remember. But our bid is very blended through all of our different sectors. So as the bid goes in, I'm going to send it into the Department of Health at the same time as it goes through the regional sifting, just so that we can make sure that it hits where we want it to. We're going to share incrementally the building of the bid. I think Ali wants to come in on this, John.
Ali?
Oh, thanks, Chair. Thanks, Kate. I just want to say I'm really excited about the work that we're doing around neighbourhoods in Cornwall. And yesterday we talked, Kate, didn't we? And Emma, you were there as well. We talked very much about we'll get our bid in, but the bid has got one lens on neighbourhood working, and it's quite restrictive, isn't it, in the application? There's only like 200 words for different questions that they specifically ask. But the thing that was really exciting for me, John, was that we were talking about actually that's one thing, but what does our blueprint look like for neighbourhood working? And that's all inclusive of children's education, community services, voluntary sector, all our NHS partners, adult social care, and what's that going to look like? And that more detailed piece of work, I think, is really, really exciting and gives us a massive opportunity to do something different, co-producing it with our residents and doing something different that delivers better and improved outcomes for residents. So I'm really excited about it. Thanks.
Okay, so let's move on to the Chief Exec's update then, to committee chair updates. Now, I'm actually going to start with Neil. Where's Neil? Neil, could you start us off, please?
Okay, my microphone is working. I make no apologies for highlighting one or two things from my ICA report. I think given transition to new clusters, it was important for the committee to document progress made against the 6 million moving to 18 million investment that Cornwall ICB has made in integrated neighbourhood teams. I'd like to highlight one or two key points. Aside from the work that's already ongoing that's listed in my report, we are aware that non-wave 1 INTs are eager to join and expansion is underway. While each INT takes a different approach based on local need, and all are monitored against a common outcomes framework. So we're using the tight, loose, tight approach, which is agreed system priorities and outcomes, local freedom in how INTs achieve them, uniform monitoring of results across the system. We were fascinated by the lessons learnt by the Isles of Scilly, and one of the things that's worth noting in terms of the time it takes is the islands have developed an MDT approach across health and care for many years, predating the INT approach, and that's part of the success that's borne out here in terms of how the Isles of Scilly are coming together as an INT. I just would like to spend a little bit of time looking at transition. Key points made at this committee were concern as to losing the gains made in INT development. There will be a need for induction awareness raising in any new committees. ideas including dedicated time to allow understanding of INTs and place work using films, case studies and voices from the front line. The committee felt strongly that the existing INT framework should be retained to allow it to embed and involve, avoid reconfiguring too soon, which could undo years of progress, and accept that variation between areas is expected and necessary due to different population needs. The committee proposed to highlight to the board the need for maintaining local flexibility, scaling good practice over time, and ensuring any new leaders are inducted into the current work and vision. So that's a look ahead. Do you want me to do quality? Yeah. So I'm afraid I will provide a written report that can be appended to the notes, but the quality meeting was last Friday. I'll provide some key points. Sepsis. The report received at the last meeting has been shared widely. There should now be an expectation that all providers and their boards are aware of this issue and will be looking to deal with the issues and barriers to improvement in this area. It's to be noted that primary care has a need from 25-26 onwards to be involved in this. Sorry, I'll come back on that. That's another item. I apologise. An example of improvement that we're seeing is UHP reaching out to look at what's needed for point of care testing in North and East Cornwall. This was most welcomed. The DHC review, the Penny Dash report on safety, was reviewed by the committee. The committee felt that the content integrates well with the ICB commissioning intentions and regarded it as a good report to be welcomed. There are 9 strategic recommendations, and particularly noted was the focus on patient voice and freedom to speak up guardians. Quality assurance overall. The committee received good reports from the quality team regarding working with staff at Harbour Ward in Bodmin. As a result of some of that joint working, there has been a reduction in length of stay through Harbour Ward, and the quality team were complimentary on the engagement made by CFT staff. The committee are aware that whilst work is ongoing on stroke and fractured neck and femur pathways at RCHT, there are still shortfalls in terms of outcome. However, a recent progression in shift of accountability, and this is also included in the UEC work, has seen some early positive results. However, concerns were noted in terms of the need for the ICB now to look at EQIA assessment of the signposted shift back towards the RCHT site of peripheral clinics, including ophthalmology in St Austell. The committee received recent reports in terms of coroner's reports, and it was noted that a good open relationship exists with the Cornwall coroner team. This has drawn national attention and needs to continue through transition to Cornwall and Devon ICB. PSERF, Patient Safety Incident Reporting Framework. This is what will expend to primary care in 25-26, and the primary care team in the ICB are cited on this. The committee noted system-level risks associated with oxygen pathway commissioning gaps, and it was felt that increasing cross-sector patient safety incident reporting alignment and learning compatibility needs to happen, especially in primary care and the voluntary sector. Basically, the forward plan is difficult because we're not quite sure what's going to happen with clustering, but there will be a need to work with Devon on the important aspects of quality and how we take that back as a joint ICB in the future. Thank you.
Okay. Tom?
I'd just like to say I'm quite concerned about this idea of pulling services that are out in the community back into a central location. I really think it's against the 10-year plan, and I'd really ask for a reconsideration to reverse this decision and really understand what the EQIA says. Those people in the poorest neighbourhoods don't have the money to be able to travel, and it has distinct impact on their equality of outcome of service, and I'd really ask for it to be reconsidered.
Okay. Stuart?
So I have a slight conflict because as a partner in St Austell Healthcare, but certainly I've got grave clinical concerns over some of those services being pulled out of the community and back into, and I'd really like to see the assurances that there'll be no clinical risk associated, but as you say, for some of our frailest and poorest communities, and that's a really big deal. Secondly, I'd just like to come on to the ICA report, and I really welcome Neil's and the board's recommendation to really try and leave things as they are and not make too many changes as the cluster changes. We're onto a really good thing in Cornwall. With our integrated neighbourhood team and progression, particularly the local leadership, and that's a bit I'm really keen that we don't lose. The 10-year plan is explicit that GPs should be the conductors of the orchestra, and I think that general practice buy-in by the collaborative board has been essential for getting this off the ground. Equally, operationally, when we're working in those INTs, particularly with our colleagues in the voluntary sector, we're really getting that kind of local understanding and passion and leadership there. So I'm really welcome that recommendation and keen that that's not undone in the clustering.
Anything you want to add to that?
We have already raised concerns with, we have already raised concerns with our CHT around the repatriation of activity, which is part of their cost improvement programme. I think we do need to come back to it. So wet age-related macular degeneration, we do have an MP letter, so that's the St Austell ophthalmology repatriation. And it's also in the news today. I think explaining to our population why services are going back into a hospital when our commitment has been to take them into the community. And also, I think we have established a principle that in order to save money, we don't use it by putting a financial burden onto anybody else. Whereas the activity that's coming out of general practice loses income in terms of rental space. And in terms of people who have to pay for travel when they didn't, they are contributing towards the CIP. And in the case of the ICB for endoscopy, where the endoscopy vans stopped being used, actually written in the EQIA is that the £4,500 a week that will be void costs will be saved by the ICB. So I think we do need to come back around this, and maybe we could have some discussion in part 2.
Yep, happy to take it into part 2, if that's all right with you. Unless anyone wants to raise anything else, Steve?
Well, I'm certainly happy for the discussion to be in part 2. I know the comment about grave clinical concerns, and that would be concerning. I'm not aware of any grave clinical concerns. So I would ask with respect if there are concerns that they're shared, rather than statements being made in an ICB board. Just as an observation, recognising that as the Chief Executive of RCHT, I clearly have an interest in this matter, and I would need to note that clearly. But just to observe that in some instances, that there will be services which can be much more efficiently and effectively delivered in a different setting. And in the services that are related to here, there may be something in the order of about £1 million of additional cost, which wouldn't necessarily need to be incurred by services being delivered in a different way. I'm not aware that the NHS 10-year plan says that in every instance, regardless of cost, services will be moved to the community. So I don't believe there's any conflict with the NHS 10-year plan where some services can be more efficiently and effectively delivered in a different setting for those service changes to be made. I'm mindful there's not a paper on this in the public board. These matters are being raised when they are referred to in the private board. So I would support the conversation moving into the private board.
That's why we do that, because your comments have been made in public, Steve. So it's efficient for whom? So it might be more efficient for the provider, but it may not be more efficient for the patient. So I think we need to be clear about that. And the slides that Simon's circulating, I understand you weren't at the meeting with Jim and Elizabeth in London, but Kim was, and I think the slides have been provided subsequently. But they show us where we can save money, and it isn't necessarily in the dispersal of activity. It is around how we use the resources that we've got internally. So if we come back to that this afternoon, that would be helpful, because it hasn't been a paper circulated. And I think Neil apologised at the start of his verbal update that he couldn't write a report from the Quality Committee because it was only on Friday. Could I just pick up another couple of issues? Is that okay? So we note the move to PSERF. And for people who have been chief execs in the NHS, when we move from serious untoward incidents to PSERFs, you stopped getting all of the serious untoward incidents across your desk. So I'd say, I don't know, 15 a week of serious untoward incidents that had been raised. They wouldn't all be SUIs, but they would then go through a sieving process. With PSERF, nothing's seen till the thematic analysis is done. So there has always been a worry for me, because we piloted PSERF in Cornwall, that you miss some of the richness of the feedback of data. So we're starting to look at what we could do from a quality perspective around PSERF thematic reviews, and particularly, so in the paper that came to the Quality Committee, there were 6 domains that we were looking at, but the first 4 sort of talk to each other. Reduction of falls, pressure areas, sepsis. I can't remember what the 4th one was, Susan, can you? The first 4 domains. VTE, that's it. They all talk to each other, because if we reduce falls by keeping people in bed and they get pressure sores, then there's a possibility of sepsis. And one of the things that was in the quality paper was a death through sepsis from a pressure sore. Now, what we haven't got is the information of whether that was community acquired. So I think it would be great to have a really big focus on quality across all points of delivery, not just in our providers, but in our care homes and across our system, so that we're picking out some things that we really need to focus on, sepsis being a notable priority. But the other thing we did talk about was the P3 pathway. And out of our current waiters, 178 waiters across all of our system in the various responsibilities of different people. But of that 178 yesterday, 60 were people waiting for P3 care. And Ali will remind me, is it 0.5% of people nationally over the age of 60? Yeah, so we're still very heavily weighted to P3 care. And so Susan has been talking about, we can't do, well, actually, I'm going to say, it's not that we can't do it. It's a root cause analysis we've moved away from because of PSERF. We need to go back through those 60 people and work out at what point, if we had made a different decision, would they not be going into an institution, but would be going into their own homes? Because this is it's a bit of a civil liberty issue, but it's also a quality and an avoidance of harm issue. So Susan's going to be picking that up. I think Kim O'Keefe's really keen to be part of the process. And I know from a social care perspective that Ali and Nell, from a safeguarding perspective, would be interested. But it's across everywhere, all of our points of delivery. So thank you.
Any other points on that? Giving a verbal update. There's been a lot of non-exec conversation on this outcome from which you debriefed me on, Neil. And there is something about the NHS, as I said in my chair's introduction, the NHS 10-year plan has to be our guiding light. And if the direction of travel is from hospital into community, then, Kate, one of the things that I think the non-execs would like to have minuted, if we can't ensure the direction of travel in the way in which we've commissioned this year, because we weren't aware of the 10-year plan, although it was our own direction of travel, but the way in which we're going to have contract management in 26, 27, it means we need to be more precise and prescriptive as we go forward. So I think the non-execs, if I can reach out, and 2 of them aren't here, who've been part of this discussion as well. And I know that you and I have had this conversation too about this, along with Neil and Tarn. I think what we're saying is that it might not be prescriptive this year, but if the direction of travel is next year going to be that prescriptive, I think we just need to reach out to all our providers and say, whatever you're looking to do now, please recognise the new financial year isn't that far away and things will be reversed at that point. So why drag it back to actually have something that you know now is actually going to be commissioned and contracted at a specific level to push it back out to community, because that is the direction of travel our own board has agreed to and the 10-year plan. So shall I reach out to the 3 non-execs in the room? Is that a faithful representation of the direction of travel that's been discussed? Neil, is that faithful? Nick, is that faithful?
Apologies for being late, Chair. I have one of my many children's 21st birthday today, so my apologies for that. But thank you. Yes, but 100%.
Yeah, so I'm being I've summarised it faithfully.
Very fairly, thank you.
And Tarn, have I summarised? Thank you.
Can I just add?
Yeah.
So one of the things that in our commissioning intentions. So we're doing an academic piece of work. We're going back to Andrew Dilnott and to Michael Marmot, because all of the return on investment for non-institutional care is in both of those reports. Dilnott's a little bit old, but it's still appropriate. But our GPs are asking for the unbundling of tariff and the tendering of services. Now, to keep this economy stable, that is not a great way of working, because it will cause unmanageable financial movements. So we need to move away from that and back to how we have been working with each other across the county. So the commissioning intentions will start to bring that through, and we'll be very clear on which services nationally are being suggested that shouldn't be part of institutional delivery models. So that will all come together at the end of August. So I don't know which mode of operating we'll be in, but those they will come together for the board before we formally submit them as commissioning intentions.
So just to state the obvious, and I think it's worth. It's here. Until its functions change, the functions are as they are now. So just wanted to say that, if that's all right with everyone. The other reason why I wanted to raise the spectre of what the non-execs have been talking about in terms of commissioning is that I understand that as we enter September, the national team, maybe the regional and national team, are requesting getting into planning for going forward. So these types of conversations will be live as we enter September. Haven't quite worked out how we're going to structure that, but that's a bit of a heads up.
And we need to be aware that the national expectation is massive. So a 5-year medium-term financial plan, where the first year, the trajectories and the delivery is identified month by month in 26, 27, and then quarterly from there on for the next 4 years. So we are going to have to be very detailed.
So can I ask that to be minuted, actually, Company Secretary? The expectation as we start to enter the September window is that 26, 27 plans will be required to be articulated monthly.
Yeah.
And only from 27, 28 quarterly.
Yeah, and I think that will roll forward in 26, 27, 27, 28 will become monthly.
Yeah. That's a national request, that's not a local
And then it'll
request.
be aligned to workforce and finance and activity, so that there's a read across the whole economy, yeah.
But can I just stress, that's a national and a regional request. Yeah, thank you. Not like we're making it up on the hoof locally, I just want to be really clear on that. Okay, lovely. So anything else on Neil's either reports? And noted on the observation about the clustering issues. Thank you for both of you making that comment, and we can note and minute that, please. Tan, why don't you go next?
Okay, thank you. I'm afraid that I have to report as Workforce Committee Chair that we were not assured in terms of performance at our Workforce Committee. The reports did not triangulate, and there was no narrative report, which meant that we couldn't really understand the performance to date, other than to say by the end of June, there was 1.2 million overspent. And within that, there's limited scope to direct staff redundancies in the absence of a redundancy process. And we can't be assured at this stage that this is going to turn around in year. We understand that there's more regional oversight now, but we need these reports to be coming through to our Workforce Committee. There's going to be an assurance meeting to review month 4 in August. And we really hope that it's going to show some significant improvement in terms of the performance and a plan to bring us back on track. I remind us again that since 1920, the year 2019-2020, we've had an additional 2,500 posts. We have to not just look at agency and bank as a way of resolving this. We have to look at the substantive posts and the recurrent costs that are the issue within our system. So I'm hoping that there is going to be a clearer mitigation plan coming to the September Workforce Committee meeting.
Okay.
So I think once we see the slides from Elizabeth, that starts to tell us where we should be looking. So it isn't just back office that's grown. There's been a significant increase in clinical staff and a significant decrease in the patient-facing proportions of job planned activity. So it's a national view, but we need to understand what that means locally. So I think you are right. And for part 2 and also for our commissioning intentions, we need to use that national data to be putting in place our expectations around the scale and size of services this population needs to have in place, not what has grown over a period of years.
Posts, that is whole-time equivalent. Thank you.
I just think we touched on it very briefly, but we need to cross-check that with EQIAs across the board, where we're suggesting that more staff are needed if we've got another way of providing that particular service outside of.
How do we where do we capture that?
So the EQIA Susan's talking about relate to the repatriation of activity. That activity will require people to be recruited into statutory services to deliver it, which is at odds with the national picture around where we should be looking to reduce numbers of staff. So I think we need to.
We're going to pick this up later.
We need to triangulate everything together.
Right. Rachel, sorry to put you on the spot.
Sorry.
The only reason why I say so, my understanding is that workforce will be.
So probably in the next few weeks. So there is a drafted version with our regional directors.
Okay, and that'll help us with the wider perspective on workforce planning going forward. Is that fair?
I think there's more work to be done. I don't think it will give us the answers we want. Well, it needs to sit at system level, it needs to sit at regional level. I don't think it's going to be one or the other.
Okay, so we press on as is until.
Absolutely.
So, Talon, can you take it as read? Press on as is until we hear differently. Thank you.
Thank you. Can I just add, after the last workforce meeting, so Simon Fuller was there from the region, and he wasn't assured by what he was seeing in terms of the triangulation of workforce numbers, activity and money. So he's been taking that on from a regional perspective, and now I think he's starting to get some engagement that is helping us to understand what our position is. But yeah.
Anna?
To remind everybody that any discussions, whether it's regional, national or local, around workforce do not include our VCSE workforce and volunteering. So we do need to be thinking locally in our new cluster and regionally about how we ensure oversight and acknowledgement of that, because that's part of addressing the issue that Kate was talking about in terms of where we need to grow our workforce. My suggestion would be that we would be wanting to grow our workforce, or one of the places we'd be wanting to grow our workforce is in the VCSE sector.
Patrick.
Yeah, just to report this work regional workforce team to inform the regional model blueprint nationally has been about making sure that all aspects of workforce are reflected in where the responsibilities lie, be they at regional, system or national level, VCSE, primary care, social care. It's the alignment between those that was the part that was concerning about the first draft of the ICB model blueprint. So we're waiting to see the outcomes of that discussion as they're reflected in the regional blueprint, but that's an ongoing piece of work, but it does pick up that wider concern.
Yeah, apologies, I couldn't see the report in the pack, so I might have missed it. Of course, each provider does have a workforce reduction plan, which providers monitor and manage. That's the case for CFT, for RCHT, for UHP, for SWAST, and Kernel Health CIC have a plan in which to manage within the resources available. And that does set out clearly the workforce reductions where there are workforce reductions, and they are a combination of bank, agency and substantive and fixed term contract whole-time equivalent reductions. Just to observe that in specific instances where additional staff are required, I think all organisations operate a first principle of firstly, can those staff be redeployed from elsewhere within the organisation to limit workforce growth? but recognise that there might be some skill-specific areas which require additional specific staff. And we've talked previously that can include, for example, specialist capital workforce roles and other areas, but wherever possible, those workforce individual increases are restricted through redeployment or through other mechanisms to minimise workforce growth. And I know that is the case in each of the providers who take action to manage within the financial position. And of course, as a system, and for the providers within the NHS system, providers and the system continues to be on plan at the end of month 3 overall from a financial perspective.
So I think what I'm hearing from Tom, Steve, is that recognising that you're saying they're there, I think you're saying you're not seeing them.
Not seeing.
So is there the opportunity just to see those plans? Because if you can't scrutinise what you're not given, I think that's the absence of the information is what you've shared with me before. Is that fair?
Yeah, absolutely. And I think that the biggest concern for me was that we're seeing underperformance to month 3, but a projection that everything's going to be okay without a narrative that actually explains how that's going to happen. I can't give assurance on that basis.
So the Workforce Committee has taken action on the back of it. We didn't have representation, but the plans that were presented in aggregate for the whole of the county told us a different story, whether you were looking at activity, money or people, and therefore there could be no assurance from the Workforce Committee.
It's helpful, thank you.
Okay.
I was just going to, I think if it's an information flow piece, we can, that isn't difficult to make that flow. We just need to understand when and how.
I think regional colleagues were very surprised.
Yeah.
About the lack of engagement at the Workforce Committee, hence Simon now taking action, and he'll be coming to every Workforce Committee because this is something we'll be doing together, even going forward, because we can't separate mainstream service workforce planning from neighbourhood workforce planning, because at place the two come together and tell you whether we've got teams that will work. So Patrick and our colleagues have developed a model with Debbie Riley at the region that is very clear about what the responsibilities will be regionally and locally. Yep. So that will still mesh together. We just need to make sure that we've got our representation right.
Okay. Right, let's move on.
Indeed.
Okay. Now, Sanj isn't here. He's given his apologies. So on behalf of the Finance Committee, FNP Committee, Simon, could you just give an update?
I can, yeah, thank you, Chair. So, noted, as you'd expect, the positive position continues to be that we're reporting overall as a system that we're going to hit a break-even position, and the year-to-date position at month 3 showed us just slightly better than planned, so that was a positive message. The committee also noted the concerns around workforce that we've just been discussing, so there are things that do need verifying and validating over the coming weeks, so that's an important exercise. They also noted the level of risk still sits there for the remaining part of the year, with the profile of CIP for our organisations being back-ended to the last 2 quarters in particular. So there is a real focus on how that needs to deliver in the way that you'd expect, and to try and bring that forward as much as possible. So that was also noted at the committee. The other, I think, positive thing to note is the complete support for the transfer of the neighbourhood investment sums of cost to CFT to manage those forward through into future years. And also there was discussions about nominating particular investments in particular INTs that supported the direction of travel that the board's been supporting for some time. So that, I think, is a positive message. Besides that, I've got nothing to add unless any colleagues who are at the committee want to throw something in.
What was the reason question of clustering arrangements, and Neil, you raised staying locally in terms of what we've done in Cornwall Hours was silly, not being undermined. I think if you look at the work in which is coming out of that committee, committing to CFT, looking to do that activity on behalf of us all, I think it's just testament that we're continuing that direction of travel. and investing in Cornwall and Isles of Scilly, not choosing to dilute it. Okay. Anything else for Simon? No? Thank you. Okay, so I think I've covered off all the committee chairs. So let's go around the partner members. Let's start with Ali on the screen. Ali, anything you want to add?
Yeah, just a few little points from me, John, but I'll be really quick. So first of all, just really good news that the hospital on the Isles of Scilly opens on Thursday. And Russell asked me to thank colleagues for all the work and support in getting to that position. In Cornwall Council, our new structures at senior level went live on the 1st of July. So public health no longer reports into my directorate, it reports into community wellbeing directorate, and I now oversee fire as well as adult social care. Both the Isles of Scilly and Cornwall await the draft CQC report following our inspections back in June. I was going to mention the assurance visit from the regional DPH, but Kate's already covered that. Performance for adult social care is on track. What I would say is that we've got out to consultation at the moment local government outcomes framework, and that really knits us together as a system around neighbourhood outcomes as well. So really linked to that neighbourhood working that we were talking about earlier today. And then other than that, just a really busy period in the council, setting the budgets and looking at the comprehensive spending review and trying to understand that for Cornwall. Thanks, Chair.
I actually thought our first committee in common, Ali, in terms of the Health and Wellbeing Board and the Integrated Care Partnership, I thought went particularly well. And I think just shows how the two councils and ourselves are increasingly maturing and working closely together. So can you just say thank you on behalf of us for that, Ali? Okay, any questions from you? Any questions? No? Steve, anything? Welcome back, by the way.
Thank you. Just to pick out a couple of brief things, although Ali's already mentioned it, I did want to start with the Isles of Scilly new hospital wing. Margaret's opening that on Thursday this week, and that's a huge step forward for the Isles of Scilly. So that's mentioned in the report and a really important development. It's been very, very positive to have such strong support from all ICB partners on progressing that. So I thought firstly we should celebrate that in the provider report. You'll also see that both CFT and RCHT have made further improvements in reducing community hospital and acute hospital length of stay. So there's some detail in the two sections of the report that provide details around that. CFT's report includes further progress on reducing 52-week waiting list volume, so really positive to see waiting times continuing to reduce from a community perspective. And you'll see in the RCHT section further reduction in super-stranded patients, those with the longest length of stay. And you'll see some initial improvements identified in terms of access to specialist stroke ward within 4 hours. The Kerner Health CIC report includes a number of updates and also includes some further information around integrated community and integrated primary care. I don't think we've provided that level of detail in these reports previously, John, so if it's helpful to have that sort of information, we can continue to provide that. Just to provide some more up-to-date information, resident doctor industrial action has already been mentioned, but just to give colleagues the context of what that has been in reality now that we've had 5 days of industrial action, looking at RCHT as an example, the proportion of doctors taking industrial action versus the number of doctors expected to be in work has ranged from a low of 29% to a high of just under 50%. So quite significant numbers of resident doctors taking industrial action. And from the discussions that I've been having with other organisations in the NHS, I think we're seeing similar levels of resident doctor industrial action being taken place, certainly across the southwest region. I haven't been able to check and correlate that against other parts of the NHS more broadly. All providers have taken every possible action to mitigate the impact of that. And again, to give you an RCHT example, over the first 4 days of the industrial action, there's been about 160 outpatient appointments cancelled, so that's been the impact on individual patients. But we've been able to mitigate that, so there hasn't been an impact in terms of a requirement to cancel procedures or operations. So whilst there has been an impact from an outpatient perspective, that has been mitigated from a operating theatre perspective. The other thing just to reflect on is, whilst some improvements are set out, which were correct at the time of writing, the improvements in type 1 performance at RCHT, a reduction in the over 12-hour length of stay in the emergency department and ambulance handover performance time have really continued to significantly improve during the rest of this month, and that's a trend that we absolutely must continue. And whilst those performance metrics relate to RCHT, of course, they reflect work across the entire system to deliver those urgent and emergency care improvements. So very, very positive to see the level of improvement in each of those three areas, and we must ensure that that continues going forward. Thank you.
Any questions, Stu? Yes, Rachel? Oh, this one.
There was an ask. CIC actually. It just they made some requests, and I'm just wondering about how we respond to a partner that makes requests for support in terms of out of area PPI, and I think the diabetes programme that was in the vignette that you saw, they were just asking for support. So I'm just interested now how you'd respond to that.
So RCHT work closely with Kernel Health CIC on all of those matters. A number of those aspects also relates to the integration with CFT as well in terms of some of the shared services and the oversight. So we have a mechanism between CFT and RCHT with chief executives and executive directors to oversee the opportunities and the interface between CFT and RCHT, particularly around UEC, which encompasses some of these aspects. And in other instances, the relationship is direct between Kernel Health CIC and RCHT. Kernel Health CIC also have engagement relations direct with the ICB in some instances. So all of those mechanisms can be used to progress.
Pick it up.
Yes.
Okay, just helpful to know. Thank you.
So Susan, the improvement that's gone on in RCHT that Steve's referring to, can you just, for the purposes of the public, I know that people around this table may well know, can you just talk a little bit about the rapid review that went on from our last board meeting, what that meant, and your view on this?
Sure. So we agreed through this board that we would hold a rapid quality review following the work of Dr. Ian Sturgis, particularly into some of the issues that we were facing as a system around our urgent and emergency care pathways. Those issues related specifically to patient harm, both potential for the future if we continued the way we were going, but also the harm that we knew was happening. Some of that harm was around having overcrowded and very busy ED departments, which is a well-trodden path in terms of research, and some of that harm was around hospital-acquired deconditioning. So we touched on it very briefly. People who possibly have come into care fully independent and for whatever reason after a prolonged stay either in hospital and community hospital or both have ended up not being able to go home and into a care home where we know your average span in terms of life is cut quite dramatically. So the rapid quality review, our providers asked us, first of all, if they could just take some time to be able to review all of their own internal processes, particularly in line with UEC, and for CFT as well, that touched on mental health. And as a result, we've decided as a system that we'd repeat the exercise for mental health, but I will come to that. And then we came together as a system to do a rapid quality review. I pulled together a draft improvement plan, which we signed off at our follow-up quality rapid review, which was last week, the week before, which as partners we've signed up to. And what that quality rapid review plan does is it doesn't create something different, Chair. What it does is it takes into consideration the plans that RCHT had already got well underway in terms of their internal clinical vision of flow, but also the 7 pillars that as a system we agreed around UEC. The rapid improvement plan overlays that with quality outcomes, of which we've agreed now a clinical audit programme. And that clinical audit programme specifically targets those issues that we know potentially create some difficult situations for patients, like sepsis, like VT, like fractured neck of femur, thrombolysis. So we have agreed a clinical audit programme. I've spoken to our clinical partners. They are very supportive of this. And we've also created an 8th pillar for mental health services. So then we can take a view as to whether or not we need a wider system. And I suspect we may well need to, because we still have a higher than desired out of area placements.
Thank you. So just before I bring in Steve, can I ask, from your seat and the clinical team seat, is there a consensus that the introduction of the rapid quality review has been a positive impact? Is there a consensus on that view?
Absolutely, and I think there's lots of lessons to be learned here, because whilst we felt that there was escalation happening within our system, the rapid review has really consolidated all of that, brought it together, has given us a more of a laser focus on some of our issues. And I think, as Steve has just reported, the July sprint has also helped as well, and we're seeing some really great recovery around UEC, and we've been able to agree and target the areas that we're still seeing some issues are out of hours areas, and that's not specifically a problem just for RCHT, it's for the whole system, and how we try and provide better services, not only in our community, but working with our ambulance service as well, to ensure that people are not going to ED overnight and having to wait there until services are available in the morning.
And if, Rachel, if I can just reach out to you, just to say thank you for your help and support in working with Neil. In terms of Neil, your committee now particularly focusing on the agreed escalation process for quality, and you'll ensure between you that actually the designated escalation process we stick to and escalate at the appropriate moment. Neil, you happy with that? Yeah. Susan, you happy with that?
To our regional quality group, and I've been invited back to do a deeper dive, because it was received well by the rest of the ICBs who are facing similar issues and wanted to understand what we had done to start to address our issues. So I think I'm due to go back in September.
Escalation process, that's what I'm trying to establish. We have the committee, the chair is clear on that, and we will go through that process as needed, okay?
What it will mean, though, is that our organisations will need to get used to being enhanced surveillance. So
it's a common parlance that I think we haven't been using, that we will be using.
But it will be a change for provider boards. So we probably will have some parts of mental health and advanced surveillance for out of area placements. So we just need to be really clear that then we're flagging to your quality committees too, that there are issues that we need to be looking at closely together.
We will also take that through our contract review meetings as well, because that's where it needs to be landed.
You want to make a point?
Briefly adds to that. So the actions that Susan described have been really important. When we see them alongside the opening in Royal Cornwall hospitals of the acute medical assessment and treatment service, which has enabled the medical take to move out of the emergency departments, and the implementation of the release to rescue 24/7 timely ambulance handover protocol 45, both of which have happened over the course of this month, the totality of that impact has been really significant. We still have 3 days of the month to go, of course, John, and I'm not kind of preempting that. But currently ED type 1 performance has improved quite significantly to 58% month to date, which is ahead of our system plan for the year. ED type 1 over 12-hour percentage has reduced significantly to just over 7.5%, which again is ahead of our plan for the year. And ambulance average handover time is improved significantly, reducing to 42 minutes on average month to date. All three of those key indicators are now significantly ahead of the plan that we collectively have and RCHT holds at this point in the year. All three of those metrics need to continue to improve further, but those performance measures are significantly improved on the prior month and on the year-to-date position.
Three things that had created this change: reform internally, which is the structural things that you're describing, Steve, GRIP, and I've forgotten what the last one was, Susan. I've gone back into my book to try and find it, but it was transformation, GRIP and clinical leadership. So it was palpable that those things had started to. So there were 2-hourly huddles that were put in place. We saw a massive increase after the 2-hourly huddles. So when we go on to the assurance statement this afternoon, it's clear to see where that we've had significant improvement. So it was great.
And we should recognise there's been significant improvement. I recognise the language, if I may say, Steve, of achieving plan. I think what came out for me in our last board meeting is the opportunity given, is it 123 that we're benchmarked against?
127.
No, but what I'm saying is there's still a lot of room for improvement beyond plan. I think that's the point being made to us.
But we were given some hope as well, because Vanessa Williams from ESIST is working in the hospital. And she was very clear that from the capacity and demand work they're doing, we have an issue as an economy between 4 o'clock in the afternoon and 9 in the evening. And Rachel asked the killer question around deployment of staff, both in the hospitals but also in the community, for those to receive that activity, because it isn't acute activity. It could be managed elsewhere, which would then give our CH team headroom for the night. So that's also in our plans.
Lots of learnings.
Yeah.
Sounds like it's going in the right direction. Thank you very much. Let's move on. Adi, from your seat, please.
Things. We've seen some investment in neurodiversity services for children, and we're just working on trajectories and reducing those waiting lists in a planned manner. Performance in access to children's and perinatal services is good, one of the highest in the country still, which is a good thing. We spoke about out area placements, which is a cause of concern, and internal review, and then we'll see where that gets us to. But also some movement on capacity and modelling coming up soon as well, so that will give us a bit more capacity as well. But we've got to work all of that through and again come up with a coherent plan for how we get that back on track, because I think we're double where we were expecting to be. And then the big thing is the opening of the Brook, which is in Dawlish. Debbie and Adrian have been, and they say it's a wonderful facility, and it is a good. So going forwards is just showing in terms of how we start to work together with the likes of DPT and other mental health organisations as we come into the cluster, so we can manage some of the demand across, so we can show we can work together in this. How do we share that wider?
One of the things we do. Bedded journey in terms of mental health services, because we are seeing some blockages both in the nest and that is driving some of our out of area placements. So Ali, it's probably something we need to pick up through the ICP or the committee in common, so that we've got an exit for people who've still vulnerable but don't need bedded care.
Okay, thank you, Adi. Thank you. Are you there, Smitesh?
No, he wasn't earlier.
I can't see him.
I think he's dipped out. Oh, there we are, Smitesh. Hi. We can't hear you. We can
now. Can you hear me now? Okay.
Yep.
Apologies that I can't be in the room with you today. So as far as my update goes, I think most of what I wanted to highlight has been covered by various members of the board. I think I wanted to just say thank you to the board for getting us where we are today, and I've tried to keep the update as positive as possible. It does highlight some ongoing challenges in various areas of primary care, which we are seeking to address, and certainly some of my role there to try and bring some of the other primary care medical services along with general practice more focused into integrated neighbourhood teams is some of the work that I would like to do moving forward. I think one of the key things, and we've mentioned it on several occasions, is that Cornwall is ready for the 10-year health plan and the NNHIP as well, and I think a lot of work is being done and has been done to make that a successful bid and application. I included within the paper as well a successful second day highlighting the progress that INTs have made. In terms of challenges that remain, I had written about the resident doctors' strike, just a short paragraph within the paper. That was last week. However, having had the unfortunate need to engage with emergency services both within primary care and secondary care, and bearing in mind that 25% of our population faces UHP over the weekend, I can say that a lot of work has been done to make sure those services are not suffering as a result of the resident doctors' action, and all stakeholders concerned with that are working extremely hard. I can only thank all of those staff for the experience that I personally had with my family over the weekend. I guess the key things, the other thing that I also wanted to mention, which came as a slight surprise, was obviously the sudden closure of Launceston MIU, which has affected some of the primary care medical services across the north and east of Cornwall. And I understand there was some reference to that in some of the papers in part 2. The key things from a primary care medical services perspective are, I think, have been touched upon, is to not lose what we have and to not lose that local leadership, particularly where integrated neighbourhood teams are concerned. And some of the work that myself and Stuart and others are doing to engage some of our partners in Devon is not only to spread some of the good work that we've done, but also not to lose or dilute what we've achieved here in Cornwall. Thank you.
Bring in Nick first. Nick?
Yeah, thank you, Chair. Note my conflicts of interest with pharmacy, but just wanted to thank Smitish for his report, but also to bring to the board's attention that community pharmacies in Cornwall have been shortlisted for a national award. So we don't get to do HSJ. Our national, one of our oldest publications is called Chemists and Druggists, which tells you where we've come from and where we're going to. And druggists, indeed, Chair. But this is a really good example of the cancer pilot referral, which has gone in the west of Cornwall. So it's a national NHS England trial, which runs across community pharmacies where they get direct referral into secondary care, potentially for a 2-week wait, whilst notifying general practice. And that, for our local implementation, has been highlighted and shortlisted for a national award. So I think it's given all the flavour of what we talk about, INTs, integration across different partners. I just thought I would make the board aware that they've been shortlisted for that award. And thanks, Smitish, for his report. Thank you.
Thank you. Okay.
So just on ophthalmology referrals. So optometrists are writing to general practice to ask for a referral onto secondary care, and general practice is then cut out the middleman, my contact be direct referrals, which just leans straight in, doesn't it, to why we're asking talented people to use general practice as a post box. So I think we need to pick that up, because I can understand why people would push back. And then my second point was around the closure of Launceston Hospital. So I have been really clear with everyone, we've handled that so badly that our trust levels are really low across the county. There's a public meeting tomorrow, so we will be going to it. Chris is going to come from an ICB perspective.
And that's at Launceston Town Hall.
That's at Launceston Town Hall, so that we can assure the population that they're very important to us, and that we have every intention of making sure that they can enjoy good access to services. Alongside that, we've got the closure of West Cornwall Hospital from 10 o'clock. So unfortunately, from an overview and scrutiny committee only just established, and from new councillors wanting to work with us, we're looking like we're not working with our people. So I think we need to up the comms and up the engagement prior to decisions being made, rather than making the decision and informing people. So I just wanted to apologise on behalf of the board and to say that we've got it in hand.
Are we able to share at all, as the day goes on, what's going to be shared tomorrow in terms of, is that now or later?
So we've got Launceston colleagues coming to the AGM, so I think they'll be asking some specific questions.
I think at very least the board should hear what the plan is over the summer.
Through that we well, certainly Tamsin and the wider team have been engaging a number of different apps. September we will have something up and running in there by the 15th of September. We've gone to a number of areas. I'm just going to pick up with Chris in terms of talking with GP practice, PCN, as well as ACIC. So we've got a number of different walk-in services within Launceston. How do we make a more resilient walk-in offer? How do we cover off against all of them? The plan is to get something open before the 15th of September. As soon as possible. We're looking at a number of different options which we're just working through. Yeah, it will be.
Well, just to add to what Aidy just said, so I'll be meeting Helston Medical Practice tomorrow. Before that meeting, they have Launceston Medical Practice. Thank you. They have a locally enhanced service minor injuries contract, but they don't have the capacity. So I've asked the primary care team to go back and look at the staff that CFC have spared to say, why don't you work together using the Les Minor Injuries contract to support the primary care hub, which already sees 80 patients a week next door to the MIU. But they're pre-bookable appointments. So I think there's a way forward that something can be done before the original idea of it reopening in September. So that's an active piece of work.
The NMC.
Yeah, absolutely. And we've got a lot to be doing on the engagement.
Yeah, that's right. Okay.
So if we'd have started the hierarchy of closures of MIUs as part of supporting Trellis in a holiday season, and the first place we close is Launceston, and this happens every single summer, and in the past we've circulated the document, and then we can explain to people why that's the case for resilience of other minor injury units. In the winter it's a bit different because we haven't got so many tourists around, but I think we need to go back to the fact that we do have that, and this has happened probably every summer. It's not great, but MIUs are a dying breed. There are a couple of nurses who are very qualified working together. They are very, very volatile because of that. So we need to have much more substantive arrangements and move to UTCs across the county. So I think it's great to have the conversation. It's just sad that we're doing it from the back forward rather than from the front out.
Lovely. Thank you, Smitesh. Happy to move on? Looking at the clock.
Yes, I think so.
Okay, so we're going to move to partner members. Emma.
Thank you. I will be brief, but in the spirit of your update, John, and reflecting on the last 3 years, I did just want to indulge the board for a couple of minutes just to focus in, because I'm usually here in my role as advocating for the wider sector, but today I'm very much here in my Chief Executive of Cornwall Voluntary Sector Forum role. To reflect on the investment and the impact of infrastructure funding over the last 3 years from both Cornwall Council and the Integrated Care Board and its predecessor, the CCG. 3 years ago, both those organisations recognised the vital role of having an organisation who sits in between public sector and our VCSE sector. An organisation who can focus on connecting, supporting and promoting the sector, investing in Cornwall VSF in a scale that, to be frank, we haven't seen in other parts of the country. So I think this again is another recognition of the vision and ambition of Cornwall in recognising the significant role that VCSE infrastructure and alliance can play in supporting the work of the ICS more generally. We don't tell our story of impact in terms of life saved and places, buildings reconditioned and community supported. We work in the spaces in between. It's work that often isn't very well seen. It's about influencing, it's about engaging, it's about challenging sometimes us all to see the VCSE as an equal partner in the design and delivery of services, and to reflect on how we can continue to hold our ambition of channel shift and to see increases in investment and resourcing into the sector. And I think in Cornwall we have done that. So I think we should be congratulating ourselves. I just wanted to just share a number of those high-level impacts which my organisation has enabled over the last 3 years. Nearly 1.3 million investment into grassroots VCSE organisations. We've talked about that at this board before, but I think it's something that we should be really congratulating ourselves. It's something that I'd like to see us continue as we move into a Devon, Cornwall and Isles of Scilly cluster arrangements. But that's a kind of one element of it, because we've also put £900,000 into the VCSE through our ICAs. So actually, although my covering report says in excess of 2.5 million, having recalculated, VSF have put £3.3 million of investment into our voluntary sector organisations over the last 3 years. And that's been done through the investment from Cornwall Council and our ICB. But we've also recognised that our workforce is absolutely fundamental to being able to deliver across Cornwall and the Isles of Scilly. 814 people have received training and development support through our investment, 225 people with mental health support, including free counselling. And when we look at our social return on investment for my organisation, we are looking at a return on investment of £3.41 for every £1 invested. And I think that's a demonstration of the significant value that VCSE infrastructure investment can deliver. I just wanted to take the time, given that we're reflecting, and this may or may not be our last Cornwall and the Isles of Scilly board, to thank this board and all the members for continuing to support our work, to our members, and some of them are in this room today, for continually challenging me and my organisation to do better, to listen more, and to change the way that we deliver services. And this autumn, once again, we will be convening conversations with our statutory sector partners and, importantly, our members, to help for all of you to be setting our strategic priorities for the next 3 years. I hope with ICB mergers ahead, we will continue to invest in the in-between, in the infrastructure, because it is delivering significant impact for the sector and for our public sector work in Cornwall. And I would just like to hope that everybody feels that this report and the impact appendix that's attached is a demonstration of how important it is to continue that impact. And thank you for indulging me and being able to just run through it, John.
Very happy. Thank you. Any questions for Emma? No?
We should just say just thanks.
Yeah, huge.
Yeah.
And lots of great practice to replicate elsewhere.
Indeed.
Okay, now I'm going to press on because we have a drop dead time, the AGM. So anyone who wants a natural break or to grab a coffee, please, if you can, one at a time, pop out. So I'm going to press on with your indulgence. So
with apologies,
Kate,
sorry, I just need to step out. I'd scheduled a quick.
Yes, that's what I'm saying.
Yes,
sorry. It's only because we've run on, and if it wasn't for the AGM, I would let it run on. So not a problem, Steve. Thank you so much. So let's move on to neighbourhood health next steps. Kate.
Okay, so are we not having a break?
No.
No, okay.
That's what I was just saying. Yeah.
All right, sorry. Let me find my paper. Sorry, I wasn't ready for that, John.
Come back.
Yeah, can you come back? So I can't find it in the...
Terry, let's just jump to doing this in a reverse order. Can we do the fit and proper person test assurance? Because I think that's probably the easiest one to cover off.
Yeah, indeed. So this is really just a we're required to, well, rather the chair's required to certify annually to the NHS England Regional Director that all our board members, our ordinary board members and our executive team are fit and proper persons in accordance with the relevant bits of the regulations and guidance. So what all this paper does is confirm that those tests have been undertaken, that the individuals concerned and listed in the paper have submitted their personal self-attestations. We've done some check-in across all members listed there in terms of the declarations they've made, and can confirm that all those individuals meet the requirements in the guidance. So it's just here to provide assurance on that basis.
Thank you. So the board is asked to note the content of the report and take assurance about the fit and proper person tests are being conducted. Is everybody happy with that recommendation?
Yeah, could I make an addendum? So it's changed slightly, hasn't it, Terry, around items 12 and 13 of fit and proper person. So we should be asking the Remuneration Committee and then the board to be receiving the appraisals from my directors, so that we're very clear that of an onward referral, that that there's no outstanding grievances, reviews, investigations, and we just need to make sure the appraisals attached to their fit and proper person statement.
Yeah. This, yeah, absolutely right. This,
yeah.
Which appraisals were undertaken.
Yeah.
So I think so. Yeah.
Happy with that now?
Yeah.
Love it. Thank you very much. So let's move on to the board assurance framework.
Yeah, so this is an updated version of the board assurance framework for 25-26, and what you'll see is most of the risks that you would have recognised from last year's board assurance framework have been carried forward into this version, but have been updated. So some of the narrative has been updated, and obviously the risk scores have been reviewed as well. There are two new risks in this board assurance framework compared to last year's, and they are our two highest scoring risks now. So the two new risks relate to cybersecurity, which I think everyone would recognise is a significant risk across the country, particularly in sort of today's geopolitical climate. And then there is a high scoring risk, the risk scores 20, which relates to transition from our current ICB arrangements into the Cornwall and as I said, in Devon cluster arrangements. And really, the score on that risk is flagging concern that, for want of a better term, the distraction of putting those arrangements in place and the delays in terms of getting to the point where we can move forward those arrangements is starting to potentially impact on delivery of in-year plans and the kind of team's focus on delivery of in-year plans. So that's why that risk is scoring so high at this point in time.
Okay. Tracy?
Yeah, just to say, well, it's just said that at the time we were writing this, we were fairly confident we had a route to deliver the change and the funding in year. So that's why the risk is focused on the impact on our business as usual. I think we do need to think when we look at the arrangements later about some of the other risks that arise in terms of delivery of the savings and how that might impact perhaps on the financial risk rather than another risk related to transition. But this risk is very much focused on the potential, particularly for loss of some of our greatest talent when we've got a long delay and the ability to keep staff motivated with such a long lead-in.
Any questions on the risks?
Maybe we should ask Rachel to pick feedback, because if we are struggling, then other ICBs around the country will.
Yeah.
Okay. Any other questions on the risks? The risk. What do you need from our board to keep us safe?
So first thing to say with that is that I've always been grateful for the support that I have from all of our partner organisations, because we manage cyber across the whole system as a complete service. We are working on new proposals in recognition of the heightened threats at the moment. So we'll obviously ask for the support of the boards as we bring proposals through for further work.
Are you working with our colleagues in Devon?
So I'm increasingly working with colleagues in Devon and looking as part of our cluster work to look at how we can work in a common way across, because we've got a very strong experience in our team in terms of cyber operations. And looking to share some of that capability with Devon colleagues.
We have a plan. Okay, thank you very much. So the recommendation is to ask the board to reaffirm the strategic objectives. Are you happy with that? Yep. And on that basis, receive and consider the initial board assurance framework. Yep. Happy with that? Very good. So let's go to the risk management strategy, please.
Yes, so under the board's scheme of reservation delegation, the board has to sign off the organisation's risk management strategy and policy. So this is an update to that document that has to be updated at least every 2 years. The update has been fully functioned on by the executive. It's been taken through our audit committee, who reviewed it, asked for a few changes to be made. I confirm those changes have been made, and then we're prepared to recommend it to the board for approval. So it sets out how our risk management systems and processes should work. Clearly, as we move into cluster arrangements, we will need to revisit this and to think about how we begin to integrate our risk management processes with those of Devon. But it's important that we go into that set of arrangements with a very clear statement of how we manage risk within the ICB, which hopefully this policy achieves.
Any questions on this?
It needs to be approved.
Yeah. Any questions? Okay, so the board is asked to consider, if content, providing recognise. It doesn't actually say approved. It just says consider.
Sorry, it should say ratify. Well, we should be approved. Yes.
Yeah, approved. Can we please get your agreement to approve this? Yes.
Yes.
Lovely. Thank you very much. And just before I move on, I just wanted to say thank you.
Yeah.
For those of you who don't know, Terry is unfortunately for us moving on, but for all the right family reasons. All right. So on behalf of the board, can I say thank you ever so much for everything you've done and all the very best to you and your family going forward.
Thank you.
Okay, so move to the next item, which we're going to go back to item 7, which is the neighbourhood health.
Which I now have it. Thank you very much. So this paper is to bring to the board's attention for discussion, selecting a CFT as a legal entity as a pragmatic vehicle which enables Cornwall to accelerate INT empowerment. And part of that implies to be part of the National Neighbourhood Health Programme, maintaining statutory safety. We are in a time of flux. And what's really important for all of us is that we maintain that focus on neighbourhood through the INT and place through the neighbourhood team developments that we've been putting in place around our UTCs with extended diagnostics. So this paper is just talking our board through the work that CFT as a statutory organisation have been doing with the ICB team around making sure that we're able to move our place directors into Cornwall Foundation Trust with the place development monies, so £6 million for this year, with a further recurrency of 6 million next year, 12 million in total, and a recurrency of another 6 million the year after. So the 18 million pounds will be devolved to place as part of our scaling up our integrated neighbourhood teams. CFT will effectively become our place convener, in this paper described as the Integrated Neighbourhood Health Organisation, effectively holding the ring at place with all partners, general practice, the local authority, voluntary sector organisations, and importantly people, so people who use services, shaping and co-producing the services that they want to receive in the future, with what matters to me being threaded all the way through that. We've had lots of discussion with CFT, and kindly Margaret and Debbie have taken through their board a revised board structure which sees 2 new non-executive directors, one from primary care and one from the voluntary sector, which reflects the changing views of the organisation from its current business as usual into the convening role at place. There's a governance structure that's in development because of where we are in terms of clustering. We're unable to bring it to the board at the moment, but as soon as we've got the cluster arrangements in place and our subcommittees moving forward, then we will bring that back through to codify our governance for the future. It's important to note that that governance will cement primary care commissioning with place delivery, because we can't dislocate the two from each other. We're looking at structures that will merge our operating units, and the discussion we've started to have around our neighbourhood health application programme, as Ali's being very clear that her services are also now facing directly into INTs. So we're starting to come to large teams that are INT facing. So part of the role of CFT going forward with local authority colleagues will be to work out what that means on the ground. And so some of our GP's ambitions around everybody changes their lanyard and it becomes lanyard North Carrier rather than the different organisations that make up the team support to North Carrier will be important. There'll be a comprehensive AD programme, and that is in part National Association of Primary Carers supporting us with that, but also Patrick's team have been doing a piece of work around OD and workforce change on the ground. It goes back to the point I made earlier about region will always have a role for at-scale workforce planning, but there needs to be a role locally around how we get our community-based assets able to support their own health rather than just aggregating everything up into doctors, nurses, physios, OTs. You get my drift. So there's going to be geographical alignment with Cornwall and Isles of Scilly ICS boundary. Place geography will map all of our INT application. We are coterminous with our local authority, but we will be paying particular attention to Devon. It's called overlaps here, but I think if I lived in Bude and Holsworthy, I'd just call it normal services. 20% of our people access care in Cornwall, in Devon, so we need to be clear that we can reflect that in how we put our INTs in place. So going forward, we will be working very closely with CFT around how our people assets transfer, how we set up operating within CFT, able to discharge this function on the ground. And I think this presents a really exciting next step actually for making INTs a unit of measurement in Cornwall through which services are planned and delivered, rather than the development agenda that we've had year to date. So what I'd like to ask is for the board to endorse the preferred organisational route as an enabling measure, while full organisational design evolves iteratively. Debbie has identified that AD will lead on this on behalf of the CFT board, so the safe pair of hands for steering this through transition is in place. Approve the intention to develop a joint governance framework. I'm afraid intention's missed from this paper because we've been in and outing whether this is our last board or not, and clearly it's not. There will be more to come. Approve the transfer of place function from ICB to CFT for delivery, not for strategic development, but for delivery. Note that no reversible decisions are being sought at this stage. Each phase will include a confirm or adopt gateway, and commission monthly system level reports framed around the balanced dashboard that is described above, but we've talked about at length before. And if the board is happy with that, we can then move on to the next step of INT development.
Any questions? Adi?
I'm going to declare an interest with it being CFT, so I'll sit here for any questions, but not to infer or change the decision. Yeah, so I think from a...
Ali?
Thank you, Chair. I don't know if you can hear me. It's still breaking up a little bit in the room, but I think you said my name, so I'm speaking anyway.
Yes.
I really welcome the proposals, and I look forward to working with colleagues on how we take this forward. I just want to do a bit of a shout out there around some of the partnership governance and make sure that we get that right moving forward, and recognising some of those changing relationships between CFT and maybe the council, where they might be doing some co-commissioning together at place. So I just wanted us to pick that up in the next iteration of the work, and I'm sure it'll be picked up in the blueprint anyway. Thanks.
Nick and then Margaret.
Thank you, Chair. So again, just to say, really supportive of this to make sure that this work is future-proofed and continue, and a vehicle to do that. As you would expect me to say, making sure that the engagement is right with all member partners within an INT. Thanks.
Margaret?
Yeah, absolutely agree. Obviously,
You're not ready.
Obviously, I have interest in this, but I think what we need to agree amongst ourselves is we will do stuff and learn. So nothing is set in stone at this time, and we should just progress together and say, and forgive each other if it didn't work the first time, try it again. That's across all of the, because I think we all have the same intentions, but it's going to be tricky, but I think it's going to be well worth the effort.
Absolute organisational change, fab.
Smitesh? You're on mute, Smitesh.
Just wanted to say thank you, Chair. Just wanted to say very much welcome the board positions that CFT have put out there for VCSE and for a primary care member as well. Just a point of clarification for me: if an organisation is, for example, with contract holding responsibilities, is seen to be more suitable to hold a particular contract in a particular situation, is that something that would be considered under that flexibility that's mentioned within the paper? Oh, sorry, I can't hear you, Kate.
Primary care training hub, for example, that responsibility is discharged by Kerno CIC on behalf of the system. I'd be expecting us to be making those similar decisions as part of a new commissioning model, that whoever's best placed to do the work should be the organisation that's asked to do it on behalf of our system.
Thank you, Stuart. Thank you, Stuart.
So welcome the recommendations in the paper. I just think there's a point around the comms here that's really important to those kind of local providers around that local flavour and that local steer, and so very much around that this is the start of a iterative process. Yeah.
Very clear that general practice as the last universal service is the bedrock in which all of these changes move from. So in terms of bringing primary care in its broader sense together with the assets in the community and the expertise of our providers is how this should roll out going forward. So, and I know Debbie's absolutely committed to making it happen and she's fully supported by her board. So this isn't a takeover, it's an alignment. Absolutely. Did I not say that? Sorry.
I knew you were thinking it.
I thought I said community assets, which is you too.
But I think it's what Stuart, under the GP collaborative hat, has said this already this morning, is neighbourhood and that channel shift and INTs. It's building on relationship. One of the most important things is relationships. So this in no way undermines the importance of the relationship, not just for CFT, but with general practice, with the voluntary sector, with all of the partners. And so I think it's just an important point that we don't lose, that in no way does this stop that ongoing relationship. And going back to Neil and Stuart's point, that we don't change what we've already started in terms of the rollout of the INT model.
We have a dashboard to measure that, don't we?
Correct.
So if tell us that activated staff who want to work together is your greatest indication of health improving actions and great care. So that is the second tier of our dashboard. So we'll be able to keep an eye on that.
Emma, Neil?
Obviously, I very much welcome the inclusion of a VCSE representative, and for full transparency, that will, assuming my board is in agreement on Thursday this week at our next board meeting, that will be a representative from Cornwall VSF. And I think that really, again, demonstrates back to my earlier point with our board report today, the role of the kind of influencing and VCSE infrastructure also. Yeah, thank you.
Thank you. Neil?
Was asked the other day to look ahead as far as 2040 in some bit of work, and what I'd like to see happening. Just to reflect on that, I really welcome the enabling that's put in place to safeguard the ongoing approach, especially as we go through transition. One of the things I've always worried about when things are going well and things are exciting is that ownership is something that people like to step into. The ultimate ownership of an integrated neighbourhood team and an integrated neighbourhood is the people who it serves working alongside the people who are working in that team. For me, that's the ownership that all partners need to look towards. Thank you.
Absolutely. Absolutely. Can I reiterate that? The biggest determinants of people's health improvement is the people themselves. And how we work with them. We need to remember, we need to push ourselves even harder on this journey, even though we've come a long way. Community hospitals are not community. GPs are not neighbourhood. It's even voluntary sector organisations and hubs are not at neighbourhood. Neighbourhood is at street level. So the more that we can get deeper into the communities, the better chance we have of achieving real change for those populations that are most challenged.
That speaks to the fact that we have enough insight to invest nearly £2 million in community health and wellbeing workers. So they're also in the 10-year plan, and they are adopting streets where perhaps people have the biggest requirement for assistance, whatever it's for, and that needs to be very much as part of our gateways, the hubs, all of the stuff that we quietly did post-COVID and retained that cross-Cornwall very local access. And yesterday we had a really exciting discussion around the INT bids, and that a citizen's advice should be everywhere through our network of services, because practical help is sometimes just as useful as healthcare advice.
Okay. A few observations from myself, if it's helpful. Mark, can I just reach out to you? Thank you to you and your board for really driving this and being flexible and shaping your board to take this on. So thank you to you, and pass on our thanks to Debbie. And I can say thank you to Adi as you're in the room as well. But do pass on our thanks to Debbie. A few observations. What's in the name? Integrated Neighbourhood Health Organisation. Please don't confuse it with an IHO.
Yeah.
Okay. So if we could just note the fact that we're not approving here an IHO. Okay, this is approving effectively the Integrated Neighbourhood Health Organisation, or INTs or whatever. They are distinct entities yet to come, all right? And we hope that it goes in that direction, but that's not what this is. In terms of governance, and Ali, I'm responding to your point here, is that Kate and I are in the process of, with Kevin and Steve from Devon, about thinking about what cluster governance arrangements actually look like. And we'll be using August, regardless of the journey that we go on. All right, we'll be using August to actually quite work out what cluster arrangements might look like in terms of governance. So I'll be intrigued, Eddie, another day to talk about who's going to be your lead player in playing into that, because this and looking towards IHOs is actually going to be part of that type of discussion. Is looking to the different way in which we deliver the 10-year plan. It'll be looking to make sure that we drive this. I put a smile on my face when I hear so many colleagues around the table going, please let's not lose all this, because I'm not quite sure who's making the decision not to do this. All right. The ICB or Cornwall also say will still be a sovereign board going forward. All right. So it might have a slightly different membership, but I just can't see that board not being excited by this and driving this and supporting Margaret this direction of travel. So I just wanted to say that. But I do want to pick up, Ali, on your point about there is something here in terms of the way in which this actually works with the councils that we've actually got. So there's a lot of work for me to think about the way in which it works with local authorities, the way in which it works with general practice, a lot of service operation that's at place level, street level in terms of community health and wellbeing workers, social prescribers, a whole raft of different people at place level that are going to be woven into this. So I think there's a large piece of governance work that just captures, without slowing it down, frees it up, but doesn't actually step back and lose its accountability. So I think if we can use a fresh pair of eyes, not to bring what we today do in terms of governance, but look to each of us to sort of say what's fit for purpose to achieve where we want to go, then we're really looking towards, aren't we, to how we engage with everyone as we go through August to actually work out what's a new governance structure to make sure all this works. So I thought I'd just say that.
And Nigel Morrison actually is picking it up in the chat. I know it's not a question, but he just wants to say CSPT will need to consider carefully how people who use services are fully engaged with this develops before any decisions. I think actually that will be the INT's responsibility. Yeah.
But the decision should be taken at the neighbourhood.
Absolutely.
Work to do on public understanding of how this goes forward. Otherwise, people always, and naturally, people link to an organisation and say, okay, they're in charge. And that's what people kind of need in a way, is an understanding of who's going to be accountable. We need to work on that.
You collectively need to work on communication and engagement.
To help that process as we go through also, because, for example, Kate and I and Steve and Kevin want to contribute to it as opposed to being the leader of it kind of thing.
And Ali's offering her contribution.
No, absolutely. And they'll be in there. So there is something here, Neil, I don't want to lose while we're on this topic and while we're in the public sphere. Message sent isn't always message received, because people fill the vacuum with their interpretation of it. So whatever comes from the national and the regional teams, Rachel, down to us finally once we've worked out what we're doing, I think the absolute moment has got to be articulating on one sheet of A4, not a 70-page document, what does this actually mean, such that the reader of it actually says, whether I'm a member of staff in this organisation, whether you're a citizen or whatever, whether you're a GP, etc., you get what this means, and we don't allow people to fill a gap with the wrong answer. And I think that's going to take a bit of working out, but we've got to work out how we do this simply, clearly, and then articulate it.
And it should be.
Exactly, I'm completely with you. And as we move, before I bring in Ali, as we move into a position where, depending on another Health Act, I'll probably have to change this, the change of integrated care partnerships going, potentially the end of health and wellbeing boards, potentially going. Could we put in, it might be at place, neighbourhood or whatever level, that would engage support from councils to do that. So it can't be an ICB only thing.
Absolutely.
Here. So this for me is why, Ali, I'll hand over to you in a second, but this is why this has to be a complete engagement of the system to be able to say what's the new fit for purpose without stretching what we do now. Let's not throw away what we've done now, but let's not start from there. Let's start from the answer of going forward and work backwards. Okay? Ali.
Thanks, John. Yeah, there's just 2 points I wanted to make. So first of all, I just wanted to say roles and responsibilities of different agencies and duties remain those agencies. So I just like to be clear on that, because people say CFT need to do this, and the statutory responsibilities for adult social care will still be mine, and I'll be accountable through the council and the elected members. And then I just wanted to really reinforce, and I put it in the chat box, but I just wanted to reinforce this. We don't have the answers as the people sitting around this table today. We might have some of them, but we don't have all of them. And it's really important that we are engaging with our communities to understand not just what's the matter, what are the issues that we can resolve, but what matters to them and what really is going to make a difference. And I feel really strongly about that. And I think that that's really, really important. So actually, when you've got that one page of A4 that you referenced, John, residents recognise it, but it's because it's their work. And I think that's really important as we move forward.
Completely agree. Okay. So let's carefully go through each of these recommendations. I think we're going to tweak a tad, if that's all right. So we're going to we're making a note that's not an AIHO.
Yeah.
Okay. Endorsing the preferred organisational route as an enabling measure while the organisations fully evolve iteratively. Endorsing doesn't commit us. It's just saying we're going where we think we're going at the moment. Everyone agree?
Yeah.
Okay, fine. I think are we using the word approve? We're agreeing to having a development of a governance structure as opposed to approving one. You could have I read it as we're approving the development as in it's been done. Whereas I think we're approving, let's get on and do one. Yeah.
Yeah, as long as we put into it that the governance structure has to unite primary care commissioning with place delivery.
Yeah. And it needs to work within. All right.
Or that might be different for.
Let's be really.
Yeah.
What will work for Devon will work for Devon.
Yeah.
All right. If there happens to be some learnings and benefits of overlap, fantastic. I'm sure Kevin will be fully supportive of that.
And I think that comment's really important. When we set up, we were very clear that place development was organic and it would be developed by people in place forming new relationships. This now doesn't become an ICB will tell you what to do. It's still that same process.
And while we're in the process of just celebrating the last 3 years, Kate, if you think about, and it was to be fair to you, you drove this because I was a bit more impatient than you, I seem to recall, in the early days. There is something about getting the local teams, and Neil, you've always been the advocate of this, the local teams to drive, less of a top-down scenario. I think if what we can do is recognising where best practice is, to me, where I've done this elsewhere, where you create value, people come. And therefore, if what we can do is create value locally here, I suspect others will want to replicate what we're doing. So what I said earlier on is don't see this as a threat, see this as an opportunity based on this is a leading direction of travel. If it flies here, why would others not want to take it?
And we may be at the forefront of best practice.
Correct.
So, and I don't see why we wouldn't want.
Correct.
And to just carry on through our.
Okay. So how do we capture point 2? What do you think recommendation 2 changes to?
So I think rather than approve, we could just go with support the development of a joint governance framework with the ICB that unites primary care commissioning with place delivery and works within the context of cluster governance arrangements.
Lovely, brilliant. Are we happy with that? Thank you for that indulgence. Number 3, I think this is an important to prove.
If we're supporting the development,
That's any decisions have to then come back to board to be signed up.
we're saying that.
If we can make the point, these things, until we know different, sit with the ICB boards.
Yeah.
Okay. Point 3, I think, is important. That is an important to prove.
Tracy's got her finger up.
I'm struggling to see.
Strategic development will remain a function of the ICB.
Otherwise you can't.
Okay. Happy with that? Yeah, very good. Note that no irreversible decisions are sought at this stage. Great. Each phase will include a confirm or adapt gateway. I just wrote by who. So can we again write it will have to come back at very least through the ICB board?
Yeah, until we have the governance arrangements in
Yeah.
place, because then it would delegate it.
Yes,
wouldn't it?
exactly.
Yeah. At the moment, because we haven't developed the governance arrangements.
Can I just say it again? Until things change,
Milk coming.
just worth saying it.
Lean into the microphone.
Sorry, yes. And the fifth one, commissioning monthly system level progress reports. From who?
So they'll come via.
So from CFT place
Yeah,
directors.
CFT, yeah.
Going forward. It's framed around the balance dashboard described above.
And that goes to FPC, because that's our
Or FP.
our FPC.
So the ICB's FMP. Are you happy with that, Adi?
I think.
Just.
Yep.
What's that chat that's just come in? Let's have a quick look.
Background noise.
Noise at the moment in the room.
I am sorry.
Yes,
Happy?
please.
Excellent. Really great progress. Thank you very
Thank
much.
you to CFT for
Yeah.
speed and flexibility.
Yeah, no, I
Thank
agree.
you.
Yeah. All right, oh, I've lost my papers now. So we're moving into, how about that? Bang, smack on time. A sheer chance. Okay, intensive outreach review at 5:02.
Don't let them down, Susan.
This really, I'll take the paper as read. This was a follow-up that we were asked for to bring to board, having brought the paper, the original paper, to the March board of this year. I would like to say thank you. This is really a service that CFT are running, but thank you to all partners, including our local authority, that have taken part in the 3 workshops that have been held to really build this service with very clear accountabilities, very clear objectives, and what the supporting measures are needed in place, the enablers, for example. So I understand the appointments are well underway. There's been a series of interviews already. This is from the £1 million that was put to this service from the mental health investment standard, and I understand from colleagues that the work is already well underway. We talked about in March, there was a group of people through a complex case review, 132 people that were designated at needing this service immediately. So that's the work that has been this work has been in pursuit of. However, really important to say that the work that's been done around the assertive and intensive treatment teams can't be disaggregated from community rehabilitation and early diagnosis. They all work, and the work that's been done to bring this service together is bearing that in mind.
Remind everybody, just in case people have forgotten, this review was after the Valdo Calacane murders in Nottingham, and it was noticed that the assertive outreach function that was part of the National Service Framework for Mental Health had in some places been decommissioned and had gone into mainstream community delivery. So we are putting back that management framework for people who present risk to themselves and to others, so that we can manage them well, and through that the public's protected. So this is a value-adding service in Cornwall and the Isles of Scilly with some of our most complex and vulnerable individuals.
Okay. Rachel?
No, so Susan, in terms of the outcomes and service, where will that be monitored?
Yeah, so that will absolutely be monitored. We're going through. It's very much like our reform programmes, Rachel, where we have the transformation board, and when the time is right to put it through, it will go through our contract review. However, this piece of work is very close, and I think mental health. There's a lot of lessons to be learned here. Mental health through the patient experience and the reference groups. So much better, I think.
Which committee goes to the scrutiny of this? Okay. Which non-exec scrutiny committee, please?
Quality.
Yeah. Okay, that's helpful. So the mental health programme board and then the quality.
There is a mental health programme board. Yeah.
I think we should be asking for some national metrics, because the avoidance of a homicides are thankfully very frequent. So there will be other metrics underneath that: help-seeking behaviour, interpersonal assault, substance misuse, unstable. So we just need to have all of the metrics clearly attached to the service.
So we're very clear about keeping people
Well,
was reported in the community.
yeah.
So is it worthwhile, we don't have a board, worthwhile having something back through Neil's committee in September or October, which would you?
I think from a governance perspective, it'd be good to take it back through all the quality committees just to give us an update.
Which month is what I'm trying to get at?
I think given that they're going through interviews at the moment, it might be closer to Christmas, I would suggest.
So what should I say, October?
October,
I start
yeah.
buying Christmas stuff in
Yeah.
October, so that works.
Andy Bullman started buying it already from yesterday.
Oh, can we say October?
Yep,
Yeah, you happy with October?
it's on the list.
I wasn't clear on the recommendation. It felt like more of a statement than a recommendation. What is the?
The instruction that I was given was to bring us back as an update. So it's to note the update and the progress of the work that's being done, which is the 3 workshops and the interviews.
The update. Change that. No, thank you. Everybody happy with that recommendation?
Can we say, we're noting the update that the service is in development and that by the time we get to October, it will be reinvigorated because we already have services in place. But I think we should also have a recommendation that we ask the national team for proxy indicators that would allow us to know that this service is providing the degree of oversight and support for vulnerable individuals, so that we know that it's a safe service.
Yeah. And recommendations too long, just make the point about going through the requisite committees through CFT and our QPOC for Neil to debrief here in October.
Yeah.
Happy with that?
Yeah.
Very good. Well done, everyone, on that. So let's go back to the questions. Here we go. So is there any, I've got one. Is there any other business? Okay. So in terms of when shall we meet again? Dear friends, so there's a sort of Dame Vera Lynn song in there somewhere, isn't there? All right. I think I just need to alert you to the fact that we don't know what we don't know in terms of any national progress on clustering. But what's quite likely is in the event that things move quickly through the company secretary, you won't be here, mate, probably. Right, but through the company secretary, we will be convening extraordinary board meetings quite conceivably as we go through August. For those of you who can attend, fantastic. For those of you who can't, we understand. But if we get a green light, we will convene, Kevin and I, things really quickly and move at pace. In the event that you don't hear from us, you can work out what's happening. Okay.
It's worth us sharing the hierarchy that we shared with our staff yesterday, that a chair has to be agreed by the Secretary of State.
Yeah, you do.
So chair needs to be agreed by the Secretary of State. We are in that process pending Secretary of State agreement. We then need to identify a chief executive. The chair needs to appoint the chief executive, at which point the committee in common, the Joint Peninsula Committee, can come together and we can start putting the cluster in place. That then allows us to go to the next step of executives and executives' direct reports in terms of establishing our structure. So that's the cadence of decisions that needs to be made.
Yeah. And the only other one that I would add to that, Kate, is that although the decision on the Secretary, by the Secretary of State on the chair to kick things off is one thing, of course, there are other decisions, probably engaging Treasury, that actually might require sign-off before we go too far down the journey. So there are a few key hurdles to get over, but if we get over those, then we will convene an extraordinary board meeting. If we're not ready for that, we will see you in September. All right. Shall we leave it there?
Yeah.
Thank you very much, everyone. Let's close it.
Thank you.
Thank you, everyone.